I guess we're being recorded. So we have our resident rounds, our fellows rounds, 1 month later than usual, which is the Thursday before summer vacation. And we'll start with Eugene Mehta. Eugene is a member of our fellowship program. He's in his second year, coming into his second year. He's a physiatrist that trained in McMaster, undergraduate done in Dublin, Ireland. There you go. And today he's talking about what?
Chronic low back pain and antibiotics.
Perfect. So take it away, Eugene.
Perfect. Thank you very much. All right, so we'll get started. So as I mentioned, Dr. Curran, my topic is going to be today chronic low back pain and antibiotics, MODIC, antibiotic spinal therapy or MAST therapy. And this came about after a patient that I actually saw at the DeGroot Pain Center who presented with antibiotic treatment for her low back pain and initiated my kind of hunt into a little bit of the research behind it. I think this is an important topic because until recently the prevailing theoretical framework was for nonspecific low back pain was more of a mechanical phenomenon was complicated by genetics, biopsychosocial and environmental factors, but really not until recently, until the early 2000s, when this theory was challenged. And I think it represents an important construct for both the pathophysiological as well as for the management of non-specific chronic low back pain. So nothing to disclose. My objectives today is going to be to review the association of MODIC changes in chronic low back pain and to explore the proposed effective MAST therapy for patients with chronic low back pain and to review the recent literature and provide a framework to educate our patients seeking alternative therapies for chronic low back pain. So we'll start off with our patient. So patient X, she's a 45-year-old female with 10-year history of chronic axial lumbar low back pain and with no radicular features. Her examination was fairly unremarkable. She had some mild midline tenderness along the spinous processes from L4 to S1 and some mild bilateral paravertebral muscle tenderness, but her neurological exam was unremarkable and no dural tension signs either. She had investigations, nerve conduction studies, and EMG that were unremarkable, but she had an MRI that was done that showed an L4-5 MODIC type 1 changes with disc prolapse at L4. She had a lot of, quite a few actually, non-pharmacological based treatments that weren't that efficacious for her. She also tried a number of medications, again, not really that helpful. She currently was taking medical cannabis and NSAIDs on a PRN basis. She also did a number of interventions that, again, were not quite helpful for her. So when I saw her in clinic for the first time, she asked me, actually, do you know anything about MAST therapy? And I didn't. And so she told me that it was basically an antibiotic regimen that was undertaken in a number of the Scandinavian countries, as well as in London, England, for patients who had this chronic non-specific low back pain. And I had read some papers specifically about that, but not particularly about MAST therapy in general. Her husband was a family physician in the area, and he had done apparently a lot of research into it, and they researched a center in London called the London Pain Service, who was providing this treatment for patients. I asked her just kind of to get a sense, how much would this cost and what were the costs associated. She told me it was about £5,000, so about 8,400 Canadian dollars. So when I looked into it a little further, just to kind of get some background of what are really MODIC changes and just get a sense of where this originally started from. So MODIC changes were first described by Deroux in 1987, and he and his colleagues actually initially described it as signal intensity changes only really in the end plates of vertebral bodies. But in 1988, Michael MODIC and his team actually developed a classification system for vertebral body end plate MRI intensity signal changes, as well as changes that occurred in the vertebral marrow and the subchondral bone changes. They also talked about this in conjunction with degenerative changes that occurred in the adjacent intervertebral discs. So what they theorized, but they weren't entirely sure of what, or clear of what the underlying pathophysiology was, but they hypothesized that it was a reflection of a spectrum of marrow changes related to degenerative disc disease, and that it actually represented a unique entity that could be distinguished from osteomyelitis or other vertebral body abnormalities. They initially proposed 3 changes, or the changes that they proposed were degenerative disc disease followed by an increased axial load on the vertebral end plates caused by next focal marrow changes, and then the spectrum of MODIC changes, which we saw. Their proposed 3-step phases were type 1, which was the inflammatory or edematous phase, the type 2, which is the fatty infiltration phase, and then the phase 3, which is the sclerotic phase. There's also a type 0 that has recently been added in, and this is for occasionally reported for degenerative disc disease or prolapse that occurs in the absence of MODIC changes. So when we look at type 1 in the inflammatory phase, what we're seeing here is that there's disruption in fissuring and microfractures of the cancellous bone at the end plate with regions of degeneration, regeneration, increased vascular density, increased nerve endings, and pro-inflammatory chemical mediators. This kind of corresponds with the inflammatory stage of degenerative disc disease and indicates an ongoing active degenerative process. You can see here in the T1 and T2 weighted MRIs, the T1 in the inflammatory phase shows at the L4-5 level a hypointensity, whereas in the T2 weighted, you can see the hyperintensity, which is indicated. Type 2 is the fatty infiltration phase. So normal red hemopoietic bone marrow elements are here replaced with abundant yellow fat. And as a result of marrow ischemia, they represent the fatty stage of degenerative disc disease, and they're related to more of a stable and chronic process. Histologically, we actually see them that there's fatty tissue infiltration and fissures in the adjacent vertebral body end plates. And when we look at, again, the MRI imaging, T1 weighted imaging at the L5-S1 level, as both T1 and T2, they're both hyper intense. And then when we look at the sclerotic phase, this is the end stage of the spectrum, and it represents extensive bony sclerosis with relative absence of marrow in the areas of advanced sclerosis. And here, where we're seeing the T1 weighted at the L5-S1 is that they're hypointense in both. So based on this, I kind of was lost in terms of what does this represent. So just because a patient has MODIC changes, what does this represent in the clinical picture? I think this is a great study that was done. It was a systematic review that looked at 32 papers and 3,000 patients. To see how patients presented in terms of their symptoms with resultant MRI findings on degenerative disc disease or other pathology. What you can see here is in most of our patients that we see that are typically in the 60-year-old age group that we've commonly seen in the pain clinic, 88% of them actually presented or had degenerative disc disease. And were asymptomatic. In the patient population who were specifically with these MODIC changes in antibiotic therapy, they're typically with a little bit younger in this 40-year-old age group. And even there, you can see that degenerative disc disease is very highly prevalent with the asymptomatic population and a number of other types of pathologies that can be seen. So my next kind of questions were, is there an association between MODIC changes and back pain? Does the size and location of MODIC changes play a role in back pain? Are there quantitative changes that can explain the association? And do these changes have an impact in vertebral function or instability? So typically, as we saw in the last slide, degenerative disc disease on its own is a fairly quiet disorder, but with associated MODIC changes, we can see that it's actually much more frequently associated with clinical symptoms. MODIC changes between 1 and 3 are actually seen between 20 and 60% of those with degenerative disc disease, and the most common type is type 1, which we'll talk about a little further later on. An interesting study that actually looked at how many patients with the combination of degenerative disc disease as well as MODIC type 1 changes and were symptomatic found that 410 patients around 40 years of age, less than 10% of them were asymptomatic and 34% were symptomatic. There's also some studies that were looking at the increased odds ratio that occurs with MODIC changes in symptomatic presentation. So if your patient has between 1 and 3 types of MODIC changes, the odds ratio is 1.6 of having a symptomatic presentation, whereas actually at 4.0 if they have specifically type 1. There's also studies that indicated that pain generation was created with a higher positive predictive value with discography, specifically in type 1 changes, and less so with type 2 and type 3. This is really based on the idea that MODIC type 1 changes are more of a reflection of earlier and acute stages of inflammation, whereas MODIC type 2 is thought to be a result of previous inflammation and more progressive degeneration. The next area that I looked at was the size and location of these MODIC changes, and a retrospective study looked at the patients who were symptomatic with these changes, and what they saw was that the depth of the MODIC changes, if it was greater than 25%, patients were seen to be more symptomatic, as well as if they involved the ventral body and adjacent areas, in conjunction if it was in the lower lumbar segments of L4 to L5 region. Now, if we look from an immunohistochemistry perspective in MODIC changes, this was an interesting study that looked at patients with discogenic back pain and MODIC type 1 or type 2 signals versus their controls who were undergoing discectomy for scoliosis or trauma. So prior to discectomy in both groups, they looked at the end plates and they surgically biopsied and immunostained the areas. What they found was that in MODIC type 1 and type 2 versus the control, there was a higher prevalence of proline glycylproline 9.5, which is immunoreactive nerve fibers, which induced more of an inflammatory chemokine response, as well as tumor necrosis factor immunoreactive cells in the end plates. And when they specifically looked at those MODIC type 1 versus type 2, they found there was a higher prevalence of the tumor necrosis immunoreactive cells in the end plates than type 2. So if you look at these images, these are the images that they provided in their study, and you can see the normal images in the top of the vertebral end plate. The middle image is the type 1 MODIC changes, where you're seeing an increase in TNF expression around the chondrocytes, with the small arrows indicating the endoneural macrophages, and the type 2 is on the bottom, indicating there's a couple small endoneural macrophages, but you're not seeing that increased density and the hyperintensity with the TNF expression of the chondrocytes. So they propose that the axonally transportation from the inflammatory cells to the dorsal root ganglion neurons into the dorsal horn, activating cytokines that play a role in the activation of nociceptors. There's also studies to show into the relation of MODIC changes in segmental instability. So this radiological study looked at segmental hypermobility, which they defined as sagittal translation of greater than 3 millimeters or more on a dynamic reflection extension plane films. And what they found is that 70% of patients who had MODIC type 1 had segmental hypermobility versus MODIC type 2, where only 16% were seen. And this corresponded with surgical correlation, where they also saw that patients who had persistent type 1 MODIC changes after fusion suggested pseudoarthrosis or non-fusion. So far what we've looked at is that what we were able to find is that MODIC changes were associated with more symptomatic presentation with degenerative disc disease. The size and location of MODIC changes can influence symptomatic presentation of pain. And immunohistochemistry indicates increased inflammatory cytokines, which explain the increase in symptomatic presentation, in particular MODIC type 1 patients. And MODIC changes can negatively predispose to segmental instability and poor surgical outcomes. But how does this really relate to bacteria and MODIC changes? And this is what I was looking at next. So this initially came from a paper that was done by Sterling et al. In 2001, who challenged the conventional dogma that discogenic radiculitis, which they were describing, was related to more so compression, structural, or mechanical pathology. They suggested, based on a paper that was done by Marshall a couple of years earlier, that had found that there were raised serum immunoglobulin concentrations in patients with sciatica. And they were proposing that there's more of an inflammatory process that occurred associated with inflammatory cytokines associated with disc degeneration. So what they looked at is they suggested that the inflammation seen around the nerve roots was actually, in patients with sciatica, was related to a low virulent microbial infections, similar to those that were seen in prosthetic hip infections. So what they did is they looked at 50 patients. 36 of them were referred for microdiscectomy for discogenic radiculitis versus 14 controls were referred for other spinal deformities. They took a 2x2x5 disc tissue and they analyzed it under an aseptic technique. What they found was 53% of the patients in the discogenic radiculitis group had gram-positive cultures within 7 days, but they found that none of them were actually detected under microscopy and only under blood agar. So that was indicating that microorganisms were present, but in very low numbers. None of the patients in the other surgical group grew any positive cultures. And when we look at the bacterium that were most prevalent, we actually see that it's Proteobacter acinius, which we'll talk about a little bit more in depth as we go. These studies were replicated a couple more times later on after that by a number of other groups. And again, when we look at the proportion of the microorganisms that are there, the highest proportion was the Proteobacter acinius. So based on this, I wanted to see what is the association with anaerobic bacteria, specifically the Proteobacter and MODIC changes. So this group out of Denmark was really the catalyst for more of these assessments. And what they did is they took 61 patients, their primary single level disc herniation, and performed discectomies. All participants had an MRI preoperatively to assess the presence and degree of the MODIC changes, and they were reassessed 1 to 2 years later by a blinded consultant radiologist. Prior to the microdiscectomy, they took biopsies as well as gram staining and PCR. What they found was that there was positive biopsies of the end plates and then bacterial cultures in 43% of the cases. 84% of the cultures were positive for Proteobacter. 80% of those with disc herniation but no MODIC changes went to develop MODIC type 1 changes in follow-up. This is compared to the non-infectious group, which of the 44% with negative bacterial cultures presented with MODIC changes. So when they looked at the Fisher extract test for statistical significance for an association between the presence of anaerobic bacteria and new MODIC changes, it was predictive in the group that did have the positive bacterial cultures. Now, the interesting part is how they came about their hypothesis into how the bacterium actually was related into the vertebral body. So, specifically, Proteobacterium is an obligate anaerobe. So, and it's actually believed to be found in skin, hair follicles, as well as the oral cavity, and it's also been proposed to have a role with protecting the host organism against certain cancers. Now, when it enters the bloodstream, it's in a well-oxygenated tissues. It's not able to survive or multiply. But when it's involved in an avascular area, areas that have low oxygen tension, minimal vascularity, or low pH, it's seen to thrive. So their idea is that disc degenerative nucleus due to traumatic herniation occurred, allowing anaerobic bacteria to enter the disc through annular neovascularization. Proteobacterium would enter into the annulus, which is the avascular tissue. And then specifically for Proteobacterium as well is that it has a specific component that releases propionic acid, which has the capacity to dissolve and to generate cancellous bone. So the idea was that this inflammation would then lead to the modic changes, which precipitated the next set of events. So the first study that looked at mast therapy came about by, again, the Danish group in 2013. And what they looked at is 140 patients with persistent low back pain, type 1 modic changes, and no effect from non-surgical interventions. They did 2 intervention groups. So one had a double dose group, which was consisted of 70 patients who had 1.5 grams of amoxiclav for 1 month, and then 3 grams a day for 2 months thereafter. The second group had 2 grams of amoxiclav for the 3-month duration. They looked at patients after 6 months, and they assessed their global assessment scale, their change in spinal intensity pain with the NRS scale with delta pain scores, and the number of days without pain over a 14-day interval. And what they found was 53% noted positive response. At the 6-month mark, delta pain scores reduced to 29.96, and the number of days without pain was reduced by 22%. They did talk a little bit about the side effects, but didn't go into great detail, but they talked about substantial side effects that occurred was hepatitis in 2 patients, and minor side effects were loose bowel movements and increased flatulence that occurred in 20% of the high dose patients and between 5 and 7% of the low dose. But they did say that less than 3% of the patients were discontinued due to their drug-related adverse side effects. Interestingly, they also noted that there was no statistical difference in the response rate between high and low dose groups. The second major study, which advanced kind of the further treatment and this implication into an actual treatment model, was another Danish group that looked at 144 patients with chronic low back pain for greater than 6 months, modic type 1 changes in the adjacent vertebrae following disc herniation. They randomized the patients into either 100 days of antibiotic treatment of amoxiclav or placebo. Then they blindly evaluated them at baseline, the end of treatment, and then 1 year afterwards. Primary outcomes were disease-specific disability and lumbar pain, as well as a number of secondary outcomes. And what they found, yeah, sure. 100 days. Yep. And what they did in terms of their results is they actually were able to show from baseline to 100 days into 1 year follow-up, there was a statistical significant difference in all of their outcome measures compared to the placebo group. So specifically what they were noting is that the regions affected by modic changes reduced on MRI at 1 year follow-up in the antibiotic group versus the placebo. Leg pain fell from 5.3 to 1.7 in the antibiotic group, but rose from 4 to 4.3 in the placebo group. The number of sick days of off work during the year was 19 days in the antibiotic and 45 in the placebo. And the number of times a patient visited a doctor was double in the placebo group, as well as quality of life measures significantly improved in the antibiotic group versus the placebo group. So their conclusions were, on all outcome measures, improvement in the antibiotic group at 1 year follow-up was statistically significant compared to the placebo group. Mass therapy should be used discriminately and within the parameters of the trial's inclusion criteria and should not be prescribed without due consideration of the harmful effects and should only be included within this special subgroup of the population. Now, there's been a number of studies that have been tried to replicate this data, and really none of them have been able to do so. A recent study in 2017 by the McGill group tried to replicate this with the same 100 days of amoxiclav, but they noted a number of limitations in their study. They only included 11 patients, and 2 were lost by follow-up. So they were unable to make conclusions at the end, but there were a number of side effects that were obviously reported, were similar to ones that had previously been reported. But they did mention a new study that's actually a registered clinical trial, which is one of the only studies that's currently underway right now, and this is called the AIM study. It started in 2014, and the recruitment was completed in September 2018. There's no further information. I just checked again this morning. There's no further information kind of regarding the trial, but apparently it should be published within the year or so. What they're looking at, this group is actually from Norway, so not Denmark, and this is 180 patients, 18 to 65, low back pain for greater than 6 months, NRS greater than 5, and the patients had type 1 or type 2 modic changes with confirmed lumbar disc herniation in the preceding years. Their intervention was they did a double-blinded RCT with 6 academic centers, and their experimental group in this group actually only had amoxicillin. And then what they were going to be given this for approximately 100 days at 2.25 grams versus the placebo control group. Their outcome measures are going to be, the primary outcome measures are going to be Roland-Morris Disability Questionnaire, and they had about 14 other outcome measures over the 12-month interval. So really, after reviewing a lot of the literature here, it came back to me with more questions and answers in regards to what the next steps would be. It was unclear to me, reviewing a lot of these studies, of how long the treatment is required. What's the optimal dose? What combination of antibiotics should you use? Does resolution of modic changes relate to the alleviation of pain given the potential lag in resolution on MRI? Is there a role for antibiotics in complex pain settings? How do you manage patients with pain while they're undergoing this treatment? Do you wait for the clinical response, or do you continue with the interventions? So a number of questions that still remain to be answered. So when we follow up with our patient, we go back to our patient. So our patient actually did receive the MAST therapy. She went to London and had the 100 days of amoxiclav. And as you can probably imagine, she had no benefit from it. There's pain and functional scores remain about the same pre and post intervention, and the medication types for her pain, her dosage, as well as the type remain unchanged. But she did develop severe new gastrointestinal issues with diagnosis of antibiotic-induced gastroenteritis and colitis. So what are our take-home points? I think the most important thing to start off is, what do we tell our patients who ask about MAST therapy and for chronic low back pain? And it was really difficult to find consensus guidelines in order to support some of these findings. But I did find on the Royal College of Anesthesia website from the UK that was a consensus statement from 2013, which they actually advocated the use of this antibiotic, this MAST therapy, and they don't have an updated consensus statement in regards to this. Their criteria, which they mention, is that the patient must have lumbar intervertebral disc prolapse proven on MRI and treated either conservatively or surgically within the previous 6 to 24 months, significant low back pain of at least 6 months duration initiated or significantly exacerbated following the disc prolapse, as well as the presence of type 1 modic changes adjacent to the involved disc. They did make a mention specifically about such prolonged course of broad-spectrum antibiotics carrying a risk of complications in the individual, and the risk of antibiotic resistance within the community should be taken into consideration prior to the initiation of the treatment. I tried to look at a Canadian perspective from it, and it's very difficult to find anything really from that perspective, but in physiatry we commonly use this Top Alberta Doctors Organization, which reviews evidence-based information for primary care based on the latest information that's available, and they do systematic reviews in regards to it. So in 2017 it was updated, and they did have a section on antibiotic treatment-based MRI modic changes. And as you can imagine, they said they do not prescribe antibiotic treatment in the primary care setting. It was obviously not recommended. So this last slide is a very busy slide, and I did it on purpose because it came from a paper in Heldman and al. Who talked about chronic low back pain and something interesting called the supermarket approach. So what they talked about here is patients often come in with perspectives on what they want to have done and how they want their treatment to be allocated for the next number of years. What this approach is talking about is actually the different approaches that can be taken in terms of back pain and the treatment interventions. They talk about the storefront view, which is activity modifications. Then aisle 1 is pharmacological base. Aisle 5 and 6 are spinal injections, and then 7 or 8 are surgical interventions. And then in aisle 10, they talk about complementary and alternative medicines. I think it's important that we recognize all of these different aspects as contributing and potentially playing a role in patients' back pain. And, even this type of intervention, you could potentially put it on the list as IL-11 or IL-12 or something along those lines. I think it's something that we can talk to patients about, but I think the most important thing is that to let patients know that we're still studying it, we're still looking at it and still assessing the risk and benefits of these interventions. I think it's important to explore different avenues, but it's most important that we ensure that we're not putting our patients at undue risk or harm with these interventions. And although we may probably not advocate for this intervention, it's important to be aware and appropriately counsel our patients of the risks associated with these exploratory interventions. So my final take-home points, modic changes may represent a link between chronic inflammation and radiological correlation in those with chronic low back pain. Mass therapy is a novel approach to chronic low back pain with encouraging results. However, further investigations are necessary. And I think at the end of the day, it's important that we empower our patients in their decision-making of potential interventions using the latest evidence-based approaches available. And obviously the asterisk is there because a lot of our interventions in pain aren't necessarily the most evidence-based or high quality, but we try to do, again, that supermarket approach and advocate as many avenues to our patients going forward. And that's it. Yes.
Thank you. I missed the first half.
Sure.
Right?
No problem.
But interesting supermarket approach. But I guess when you say supermarket, how does the patient go from IL-1 to IL-2? Is it because it's sequence, or depending on what he needs, like if he needs a toothpaste, I'll just go to the IL. So should it be tailored to based on patient's need? For example, if a patient feels acupuncture works for him, let him go to IL-10 rather than IL-1.
Right. I think it's more of the idea that there isn't one size fits all for everybody. I think that if we can present the patient with a number of different avenues or opportunities for their pain control, and they will come to you from IL-1 to IL-10. Yeah, go ahead.
But potentially, in relation to discussing something that has, for example, you have N of 1, case report is an N of 1
right.
in a way, which is not blinded,
right.
showed significant adverse events, like one patient had significant adverse events. For example, in the whole treatment scenario that you take, there are many things that don't have side effects versus something that has such a big side effect. I would feel more to say that, be careful about the side effects rather than actually taking a more, let's go ahead and do that. So what's your opinion? Because the side effect risk is very high with antibiotics.
Absolutely. So, I mean, my personal perspective on this is I would not advocate for it whatsoever. I don't think, and the reason is because really the studies that I showed you are primarily the two most positive studies that were out there. And that this is what this patient specifically was, and her husband, who's a family physician, was relating most of these towards. A lot of the studies that have been conducted are, again, there's so much heterogeneity in the studies themselves, so how much in terms of the duration, the type of antibiotic, but a lot of them, very, very few of them will talk about the side effects that are associated with it. And as you mentioned, there's obviously a huge push in the community with family physicians not prescribing medications or antibiotics due to the community-acquired infections, which are occurring more prevalent today. Again, I feel that at this time there's really just not enough evidence and not enough to support that, and the risks are truly greater than the benefit that can be associated with it. Yeah.
Gene, I'm frankly surprised that the infectious disease hospital intensivist community haven't really gone crazy over this.
I am too, actually, because
at a time where antibiotic stewardship is being preached everywhere because of the huge challenges and the consequences of resistant bugs. Put somebody on clavamoxil for 100 days is borderline crazy. So I'm really surprised that people haven't just ripped these studies apart to say it's borderline irresponsible.
And
doing things like that.
yeah, and I think that there is some studies that talk around it, but there's not studies that have come out specifically saying that it should just be abolished or we should, get rid of it in a sense. There are still studies that are going on, and specifically that one I was mentioning that is currently likely to be published within the next year or so. So there is continuing research in it, but yeah, I agree.
I'm surprised any of the carriers would pay for $100 worth of cloud amoxil
Yeah.
or something like this.
Yeah. So. Yes.
So just to review the pathogenesis, so
Sure.
we're all colonized with this anaerobe, and then you have a injury to the disc, which is with neovascularization in a low oxygen, low pH environment, and it starts growing there.
That's the prevailing hypothesis that they have. So then, because it's an avascular environment, this anaerobe thrives within the nucleus, causing an inflammatory reaction, which leads to the modic changes. So their idea was if we can abolish the bacteria, we can prevent or treat this this inflammatory component, and then ideally help to, I guess in a sense, prevent or cure the back pain that these patients are experiencing.
So why are they giving it 100 days?
So that I was looking into that as well. So apparently, when you have discitis, that's the term or the duration in which that you would give it. It's over 100 days, and that's what they initially said in their papers. Why they chose 100 days and the other group chose 30 days and another group chose a different duration, I don't know. But the 100 days, that's where it originates from. It's from the infectious discitis treatment.
And sometimes, I have never done discograms,
Mhm.
but sometimes they talk about prophylactic antibiotics at the end to prevent discitis.
Mhm.
So is there any mention about prophylactic like intradiscal therapy?
No, they didn't mention anything along those lines. No. Sorry, Ed. Yes, sure.
Maybe one last question.
Yes.
Again, it's related to everything that we
Sure.
talked about so far, but you mentioned that this bacterium is useful for preventing cancer.
That was another component that was mentioned in the studies, but again,
Yeah.
one of those, yeah.
So I understand that there is
Yes.
proliferation of this bacteria in an injured part of the spine,
Mhm.
but at the same time, like Ramesh said, it's irresponsible to do this.
Mhm.
Suppressing a bacterium that is useful in the body in many other ways, just because there is a lot more of it in one particular spot,
Mhm.
the antibiotics will suppress it everywhere in the body,
Correct.
right? So
Correct.
anyway,
Yeah.
I was just thinking about the suppression of the immune system for a very long period of time and the long-term consequences of that for autoimmune disorders, for example.
Mm-hmm. Yeah, I think at the end of the day, again, the risks associated with significantly outweigh any potential benefit. It's not like we're even seeing 100% or 80%. It's 40, 50% of the patients may experience some moderate improvement, so it's difficult to justify that. Yeah.
You're publishing this, right?
I'm publishing this?
Yes.
No.
You should do, because you should really, the problem what's happening is everybody jumps into RCT without doing observational trials. Observational trials are needed to determine or know determinants, 100 days, whether pain relief is correlated to modic changes. They don't do any of this, and I'm very sure that lacks in this literature too. You should publish this and say, without observational trials, you can't capture side effects, big side effects like this,
Mhm.
before jumping into RCT.
That's true, yeah, that's right.
So when they did the study,
Yes.
modic change type 1, was there any concurrent pathologies like, discogenic, like disc prolapse, that was
So-
it just simple modic change, and then they follow with antibiotic without.
So they had to have a prolapse at the adjacent disc level with associated modic 1 type
So that's
changes.
if you have a prolapse, it's really difficult to delineate whether it's due to pain is due to prolapse or.
And I think they were trying to tackle it in terms of changing the presumption idea of this is a mechanical structural pathology, and this is more of an inflammatory type of pathology, or inflammatory base, and that's why they were associating it with the antibiotics as opposed to, and then the reason why I think they related that to as well is because that initial chart that I showed of how many individuals actually present with asymptomatic degenerative changes, prolapse, herniation, that they felt that this was more related to an inflammatory component as opposed to those structural aspects of it. But I mean, there's a lot of assumptions along the way. It was initially, looking at the modic changes with, then they did the discectomies or the immunohistochemistry, and then based on that, they added in the modic changes plus the surgical component, and they looked at after. So there's a lot of assumptions kind of made in each step of the process, and that's how they came to that conclusion that let's try antibiotics and see if this has a role. So I think it's a little bit more complex than they originally made it seem.
Sorry, I missed the first part, but do you think adding in a component where you take a sample from the herniation prior to, was there any mention?
That's what they did, yeah, that's what they did initially early on. So if the patient had modic type 1 changes, they actually looked at, most studies looked at modic type 1 and type 2, and they compared it to a control who was undergoing a discectomy similarly. So if there was for scoliosis or trauma, they then did a biopsy of the vertebral end plate and to see under immunohistochemistry what inflammatory markers, and then they also cultured under blood agar to see what pathogens were prevalent. And then what they found is there was a higher proportion or higher prevalence of the Proteobacter messinese was there, which led them to isolate specific antibiotics that would help to isolate and treat. So I think if they were doing it in a like this patient that I had, she didn't have a biopsy of her end plate, and she didn't have a discectomy or anything along those lines. So and no studies that I came across actually discussed doing that. But I think obviously if you were able to do that and you were able to tell and isolate the bacterium, I guess it would be more efficacious, theoretically.
Or that you can isolate.
Right.
And so one last thing, was there any thoughts combining it with, let's say, ozone, or which is another one that?
Yeah, it was interesting. Nothing actually talked about ozone at all. I was a little surprised they didn't even talk about. When they said surgery, the only thing they talked about surgery was discectomies, and they didn't talk about really any other different types of interventions or procedures. But yeah, no other interventions were noted in the studies that I came across, anyways. All right, thanks very much.
Good. So our next fellow presentation is from John Hakim. He's spent a year with us from Saudi Arabia, finished his training in anesthesia in 2015, correct? And did his pain training in Saudi Arabia, finished in 2018. Now he spent the year with us, about to head home soon.
Yes.
He's going to be talking about the role of CGRP in migraines.
It's been an interesting year to be in Canada last year, the years of cannabis, rafters, and I think also the pain biologics. Especially now there is ongoing phase 3 trials by Pfizer for the osteoarthritis, and for migraine there is a CGRP biologics. So let's start with the story of these biologics. No disclosures. Migraine disorder is the most common form of chronic headache that is characterized by episodic incapacitating headaches. The International Headache Society diagnostic criteria for migraine headache duration from 4 to 72 hours with at least two of the following characteristics: unilateral, pulsating, moderate, pain aggravated by movement with one of the associate nausea, with or without vomiting, photophobia, and phonophobia. So the migraine has 4 phases: the prodrome, aura, headache, and postdrome. So if we count that, the patient might have, like for one attack, like 4 days to be disabled because of this migraine attack. The prodrome might last up to 72 hours, and the headache might last up to 72 hours, and postdrome might last for 2 days also. Prevalence and triggers. Migraine have been found to impact approximately 12% of the U.S. general population, more commonly affecting women, 18.2% compared to 6.5% men. The peak occurrence in the 30s, 30 to 39s. in which 24% of women and 7% of men are affected. The lifetime prevalence of migraine for women, 43% and 18% for men. Accepted migraine triggers stress, menstruation, visual stimuli, whether changes, nitrate, fasting, wine. Others like sleep disturbances, aspartame, smoke, heat, exercise, sexual activity. The pathophysiology of migraine, current understanding is due to cortical spreading depression. It has been suggested that this phenomenon is responsible for visual aura, activation of matrix metalloproteinases, which is increased the blood-brain barrier permeability, eventually activation of trigeminal nerves afferents. These neurons act to supply sensory innervations to large vessels within the cerebrovascular system and meninges. The development of migraine headache is thought to occur as a result of cascading events within new studies, as pannexin-1 megachannels often activate caspase-1, release of pro-inflammatory agents, which lead to astrocytic activation of nuclear factor kappa B, transduction of the inflammatory response down sensory trigeminal nerves that innervate the PL vasculature. Traditionally, the treatment, prophylactic treatment for migraine, tricyclic antidepressant, beta blockers, calcium channel blockers, anticonvulsant as topiramate. These medications all produce approximately 50% frequency reduction, but require dosage and with considerable frequency of intolerable side effects. And in acute stages, if it is mild symptoms, NSAIDs, acetaminophen, for severe cases, triptans, antiemetic, and ergots. So, from the neurochemistry of pain transmissions, we know that the neurotransmitters have an excitatory and inhibitory, excitatory glutamate, aspartate, inhibitory glycine and GABA, and the others. The neuropeptide has an excitatory, which is substance P, CGRP, which lead to release of histamine, neurokinin A, CCK, there is also a study going on the CCK, and neuropeptide Y. And the inhibitory neuropeptide, enkephalin, dynorphin, and endorphins. Cannabinoids might activate the neurotransmitters, but I'm not sure if it can be considered as neurotransmitters, especially the anandamide. The target, the new target is the CGRP, which is excitatory neuropeptide. These how these neurotransmitters works in the dorsal horn. CGRP is a 37 amino acids neuropeptide containing both N-terminal disulfide bond and an unmediated C-terminus. CGRP larger family of peptide includes alpha and beta forms of CGRP, amylin, adrenomedulin 1 and 2, calcitonin. Procalcitonin has a partial agonist. The alpha form of CGRP predominates in the trigeminal ganglia. The CGRP receptors is a G protein coupled receptors with three components. Calcitonin-like receptors is a 7 transmembrane receptors. 2 receptors activity modifying protein 1 is required for both the trafficking of the calcitonin-like receptors to the plasma membrane and the coupling of calcitonin-like receptors with CGRP. I know it's a little bit confusing. The third receptor component protein, which is involved in the receptors and G protein associations. The result of the cascade following receptor substrate binding gene expression alteration affecting plasma membrane receptors and ion channel activity. So both CGRP receptors and amylin receptors 1 are expressed within trigeminal ganglia. Trigeminal system. The trigeminal system is critical to controlling cranial vasculature tone, transmitting cranial sensory information. The components of the trigeminal vascular system include the trigeminal nerves, cranial vasculature, the spinal trigeminal ganglia. It is well documented that neurons of trigeminal symptoms express CGRP. The action of CGRP and cranial vasculature lead to vasodilation of cranial arterioles, but not venous sinuses. This allows CGRP to act in the maintenance of cerebrovascular resting tone. So CGRP and migraine. CGRP's potential role in migraine was first suspected when it was shown that during migraine, level of CGRP are increased in cranial but not peripheral circulations. This study by Gotsby and his colleagues in 1990. This suspicion was elevated following study demonstrated that CGRP levels in cranial circulations can be elevated by trigeminal stimulation and decreased using traditional migraine treatment. It has been demonstrated that injection of CGRP can induce symptoms of migraine. CGRP is implicated in causing migraine via cerebral vessel vasodilations, neurogenic inflammations, nervous system sensitizations. A vasodilatory effect of CGRP are mediated through adenylate cyclase pathway, in contrast to nitric oxide or endothelium-driven pathway. The neurogenic inflammation in migraine is driven by vasodilations, plasma extravasations, which is stimulated by neurokinin A and substance P, inflammatory agent release due to interaction with receptors on mast and glial cells. CGRP causes sensitization centrally by enhancement of presynaptic release of CGRP and glutamate, increased postsynaptic neuron excitability via CMP cascade, dependent receptors phosphorylation. CGRP also causes peripheral nervous sensitizations by increase of PTX3 purogenic receptors. There is also ongoing studies about purogenic receptors antagonists, which seems to be effective in allodynia. And this is also a new target. Brain-driven neurotrophic factor gene expression. So the CGRP receptors antagonist history, the first hypothesis regarding the participation of CGRP in the pathophysiology of migraine was established in 1985. And years since, serotonin receptors antagonists, triptans, have been used to treat migraine due to their ability to decrease the release of CGRP. The definitive link was subsequently observed as increasing levels of CGRP in saliva were shown to be elevated during the course of acute migraine. GPANs. GPANs were created as a class of direct CGRP receptors antagonists that were directed primarily at the trigeminal system. Despite a relatively small molecular size, penetration of blood-brain barrier is minimal, and despite the administration of supraclinical doses of tilcagepants, no additional efficacy was observed, suggesting a mechanism of action that does not depend on blood-brain barrier penetration. And this is an important information we'll see. Unfortunately, gepants as a class were discontinued from further development before ever achieving approval for clinical use due to hepatotoxicity with prolonged exposure. CGRP receptors biologics. This class drug is too large to diffuse through the blood-brain barrier, and thus functions with peripheral tissues. The mechanism of action of these humanized monoclonal antibodies relies on the prevention of trigeminal nociceptive signaling via direct antagonism of CGRP receptors binding sites. Due to low membrane permeability and poor bioavailability, these compounds must be administered parenterally. The half-lives of CGRP receptors biologic in general are significantly longer than those of gepants, weeks to months compared to hours, respectively. Extended half-lives tend to improve patient compliance. The mechanism of action functions via selective inactivation of the alpha and beta CGRP receptors. Irenomab, the first of its class. Irenomab is a fully human monoclonal antibody. It is selectively binds to the canonical CGRP receptors and functions as a competitive reversible inhibitor. The drug is the first human monoclonal antibody to target the CGRP receptors. Binding of the drug to its receptors has been characterized as a high affinity. The drug is not eliminated via hepatic, biliary, or renal routes and thus raises few hepatic toxicity and drug interaction concern. Pharmacokinetics and pharmacodynamics of Irenomab. The capsaicin-induced dermal blood flow model was used and it's validated. Non-invasive method used to assess target engagement of CGRP blocking therapeutics during early clinical development. The CIDBF model relies on the ability of capsaicin when applied topically to the human forearm skin to activate the TRPV1 receptors on nociceptive nerve endings to induce local release of CGRP. In the model, the increase in dermal blood flow that are associated with the release of CGRP are measured in order to evaluate the efficacy of CGRP blocking compounds. Irenomab inhibits a capsaicin-induced dermal blood flow model in both healthy and migraine subjects. There is a nonlinear pharmacokinetics of the drug, successfully explained the dose concentration dependent elimination of Irenomab. The subcutaneous absorption half-life was 1.6, bioavailability was 74%, maximum inhibition reached 89%. The pharmacodynamics model verified the assumption that dermal blood flow before capsaicin challenge does not change relative to increase of Irenomab concentration. That means Irenomab doesn't cause vasoconstriction. It just prevents the CGRP release and vasodilations, indicating that the drug attenuates the action of the CGRP and the periphery. Increased body weight was associated with increased clearance but did not affect the inhibitory capacity of Irenomab. An administrated dose of 70 milligram subcutaneous every 4 weeks placed subjects above the mean of IC99 within the first dose. Initially, they tried the 23 milligram and they reached 50%, and with the 70 milligram, they got 100%. So with 100% maximum dermal blood flow inhibitions. The nonlinear PK can be described by two parallel antibody elimination pathways, a slow and a rapid one. From the data, it is expected that dose regimen equal to or greater than 70 milligram subcutaneous every 4 weeks would produce Irenomab concentration that saturate the nonlinear elimination pathway at a steady state. Efficacy and safety. CGRP is one of the many vasodilatory and cytoprotective mediators released by cardiac sensory nerve during ischemia. One of the theoretical concerns related to Irenomab is cardiovascular risk associated with inhibition of CGRP pathway. Phase 2 study shows no increased incidence of cardiovascular events an individual treated with irinumab compared to placebo, a study specifically designed to assess the potential adverse antivasodilatory effects of irinumab on a high-risk patient with diagnosed cardiovascular disease, published a few months ago, found that a 140 milligram IV dose of the drug did not have deleterious effects on exercise treadmill test performance. But I don't know why they didn't check the cardiac enzymes before and after. Another study shown that concentration of irinumab that effectively inhibit the capsaicin response not associated with significant changes in blood pressure or other vital signs in other healthy subjects and the patient with the migraine. The same result were with both irinumab and somatriptan. So this is was the first the phase 3 trial for the irinumab. It's a randomized, double-blind, placebo-controlled phase 3 study. 577 adults with episodic migraine were randomized to placebo or 70 milligram irinumab. 570 patients were included in efficacy analysis. The primary endpoint, change in monthly migraine days, and the secondary endpoints, more than 50% reduction in monthly migraine days, change in acute migraine-specific medication treatment days, that means the abortive therapy, more than 5 points reduction in disability scores. All endpoints are changed from a baseline at month. Episodic migraine was defined as at least 4 and fewer than 15 times per month, with or without aura, for at least 12 months prior to start of the trial. The study took place in 69 cities, 69 sites in 8 countries across North America and Europe. The conclusion, as a preventive treatment of episodic migraine, irinumab at a dosage of 70 milligram monthly significantly reduced migraine frequency and acute migraine-specific medications. But let us dig deep in the results. A patient receiving irinumab experienced minus 2.9 days change in monthly migraine days, compared to 1.8 days for placebo. A more than 50% reductions in monthly migraine days was achieved by 39.7 on irinumab and controlled 29.5. Migraine-specific medications treatment days was reduced by 1.2 days in irinumab and 0.6 days in placebo group. Safety and adverse events profile, and this is a study against a placebo group, not against the current used medications like amitriptyline or beta blockers. Safety and adverse event profiles of irinumab were similar to placebo. Most frequent adverse events were upper respiratory tract infection, injection site pain, and nasopharyngitis. The more than 5 points reduction rates wasn't significant. In migraine physical function impact diary were 33% versus 27% in control. In migraine physical function impact diary everyday activity were 40.4 versus 35.8. The new drugs coming in that group, the Aimovig, the irinumab developed by Imogen and Novartis, received its first global approval on May 17, 2018 in the US for the preventative treatment for migraine in adults. The drug received a positive opinion on May 31st in Europe for prophylaxis of migraine in adults who experienced at least 4 4 days monthly migraine day. Emergent list price for the drug is $6,900 a year, or $575 a month for both 70 milligram and 140 milligram dose. Three other companies have been have CGRP products in phase 3 trials, as listed. And the cost effectiveness, this study just also published recently, like maybe 2 months or 3 months ago. No, or last year. So this cost effectiveness study analysis of ironimab for preventive treatment of episodic and chronic migraine results from the U.S. Societal and payer perspective. The conclusion was the use of ironimab may be cost-effective approach to preventing monthly migraine days among patients with chronic migraine versus the Botox group, which has monthly Botox injections, and no preventive treatment in the societal and payer perspective. It is less likely to offer good value for money for those with episodic migraine, unless lost productivity costs are considered. And thank you, heading to my kids and my country. Thank you, sir.
What's that result? 1.8 day versus 3 point something, was it?
There's few of the result was statistically significant?
Yes. Yeah, it's more than 50% reduction against placebo. But do we get that with the other prophylactic, which is cheap? Beta blockers, amitriptyline.
It's not more than 50%. I think that's the relative, absolutely, just 10%.
1.8.
Between the monthly migraine days, 39% and 29%.
Yeah.
The risk, absolute risk is 10%.
Yeah, 10%. But they measure the least squares means, yeah.
Whether there's clinically significant.
Yeah.
So, Gassan, how did these results compare to other drugs on the market?
The other drugs, the market is from the other classes.
Yeah, the other classes.
I didn't see any study that head-to-head trial from the classic prophylactic.
Let's say Candesartan versus placebo.
Yeah.
In a similar population, what do we see with
the prophylactic? With the others, the classically also it had a 50% reduction against placebo.
So it's really no more effective than no.
Yes, but their logic that this medication might be approved as a third line of therapy when the patient has failed everything, as they approved in US the Botox injections. It's covered as a third line therapy. So this be compatible to the Botox injections at that level.
I thought of using this for trigeminal neuralgia, because you were talking about...
Dealing with my personal thoughts, I think this, from the pathophysiology of this CGRP, I think this medications might work for 5 months.
5 months?
Yes.
Because I was thinking, so you're saying that, so CGRP does not cross the blood-brain barrier, but you have this capsaicin-induced vasodilation that's inhibited.
Yeah.
So how does it actually affect central?
Yeah. Even the somatrocan also initially the mechanism of action by decreasing this CGRP release, and they found that when they talk about the trigeminal ganglion, so they don't need to cross the blood-brain barrier for a trigeminal ganglion. But the CGRP is sensitized in all the dorsal horns, And we saw that in fibromyalgia patients and any patients who had central sensitizations. But the studies is on targeted the head and the trigeminal ganglion, because also it's well documented that CGRP's receptors is sensitized in trigeminal ganglion and the migraine patients. Trigeminal neuralgia, I think, makes sense, but no studies. Yes?
We know that migraine is affected by the menstrual cycle, and you mentioned it at the beginning as well when you, in your review. And I'm just thinking about the effect that you had on your last slide between the difference between the treatment group and the placebo group. Over 50%, reduction in pain, 39% active and 29% placebo. I'm just wondering, did these were these groups controlled in terms of composition of men and women in the different groups, active versus placebo, and did they also control for age because of menstrual cycle and women of certain age, blah, blah, blah?
For age, it wasn't controlled. The patients, all the adults from 18 to 64, this is one of the populations. But men and I forget actually what was the difference between men and women in that group. I don't know if here.
That factor would have affected the results.
Yeah.
They would have stratified maybe.
It's a good point. A lot of times it's good to present table 1, which goes over all those differences.
The demographics.
You usually have to publish that.
Yeah.
But the intention of this presentation not to present the trial, it's to present the idea and the new class of that medications.
$6,000 a year? $6,000 a year? US dollars?
Yes, more actually. $7,000.
Is it approved in Canada? Is it something?
Yes, and it's available in our clinic.
And who pays for this amount? The province pays for it, or the province pays for it, or
from what I know, it's not covered.
Yeah.
It's not covered by.
For the same reasons, I'm surprised when the cost effectiveness with the Botox per month, though, for Botox patients, I don't think they've spent $575. So they spend $575 for Botox.
Yeah, 100 units, like $800.
But that's 2 months.
Yes.
Yeah, that's what people.
Maybe monthly. I don't know how.
Yeah, you're right, they don't get it.
Yeah, that's.
Yeah. But depends. The cost effectiveness study done in the U.S. I don't know the cost of the Botox there. What I knew, it's around like $3,000.
Because they won't get it every month. That's interesting.
Good work. Good.
Thank you very much.
Thank you very much. Thank you for the great year, and goodbye for everybody. Thank you.
How was it? Oh, it's great.